cancer patient and the fatality among the patient are still steadily increasing, especially here in Saudi Arabia, with low screening rate being a major contributing factors. To help raise people awareness and the knowledge about breast cancer, Public Health Authority and with the collaboration with the Family Affairs, Saudi Health Council, and Saudi Universities Board Federation, we're delighted to invite you to this panel or this webinar. We will discuss breast cancer screening, the screening program, and the effectiveness of this program. We have our guest speaker, both of them experts, and we are really delighted that both of them with us today. Our speaker will be Dr. Saleh Al-Isa. Dr. Saleh Al-Isa is epidemiologist, public health specialist, and researcher, and very interested in research in breast cancer. Dr. Saleh Al-Isa working at correct me, Dr. Saleh, it's the
Saudi Electronic University.
Saudi Electronic University, yes. And he held a doctorate and in epidemiology from King's College London. And he done like several research in cancer research. And we really very delighted to have him here with us. Dr. Saleh also have very strong data analysis skill and work in different areas, and like training in UK and at King's College London, and have research fellowship at University of Nebraska Medical Center. He will talk today. What is the name of your lecture, Dr. Saleh?
It's going to be a breast cancer screening effectiveness.
Yes. So he will talk us about breast cancer screening. Our moderator, Dr. Iman, also she's an epidemiologist, and Dr. Iman graduate of King Abdulaziz University, where she held a position as an assistant professor at the Department of Community Medicine. She worked at the Department of Hygiene and Environmental Medicine at Ruha, correct me, Dr. Iman, University at Germany. Yeah, where she trained in water and hospital hygiene, travel medicine, and environmental health research. Dr. Iman also had a degree in epidemiology from Ludwig University.
Ludwig Maximilians.
Yes.
German is not very easy to pronounce.
And a PhD at the London School of Hygiene and Tropical Medicine, Faculty of Epidemiology. So both of our guests are epidemiologists and interested in cancer surveillance and cancer research. Dr. Saleh, the floor is yours, please. Can we start?
Absolutely, sure. And thank you so much for the kind introduction. And I look forward to this lecture. And for those who know about epidemiology and the new research in the area, Dr. Iman is a great colleague of mine. We both attended schools in London, and we through our PhDs exchanged knowledge generously. So I'm glad she is the moderator. So today is I'm going to talk about breast cancer screening worldwide, and also in the kingdom. Is my slide up on the screen? Okay, good.
Yes, Dr. Saleh.
I'm just gonna minimize this window so I can talk freely about the effectiveness of breast cancer screening. So thank you so much, Dr. Iman, for the kind introduction, and Dr. Manal for inviting me. And I'm very thankful for this opportunity. Thank you for the Public Health Authority and the partners. I think breast cancer is a major public health problem in Saudi Arabia, and we need to push the research and prevention and also care forward to minimize the burden of it. Anyway, so just about this lecture, I will talk about what is breast cancer, and then we'll slightly talk about how to detect breast cancer early, and what is the detection method. And then we'll talk about how effective are these detection methods, and then we'll talk about the future direction of breast cancer diagnosis in light of the new advancement in technology and research. If my voice at any point goes low, or video is not that good, please, Dr. Iman, you can just warn me or heads up. So what is breast cancer? Breast cancer is a type of cancer that starts in the breasts. Breast cancer can be detected by or seen by X-ray or felt as a lump when it comes to be symptomatic. There are two major types of breast cancer, the ductal carcinoma and the invasive carcinoma. Just a quick background about cancer statistics in Saudi Arabia. These figures from a paper we recently published in the Journal of Cancer Policy in England. So cancer incidence is increasing gradually in the kingdom. I think this is due to the new adoption of westernized lifestyle, especially around sedentary life, lack of physical activity, and lack of movements. The number of incidents in 2020 was estimated to be around 25,000 cases. This number is becoming a burden now, but also in 2040, I think we are going to reach something around 55 or 60,000 cases a year, and this requires a huge amount of resources to be allocated to cancer care in the kingdom. In terms of mortality, cancer is becoming one of the leading causes in Saudi Arabia, and this is in light of the new advancement and the new infrastructure that has evolved in the last 50 years in the healthcare system in Saudi Arabia, as infectious disease was the leading cause in the 90s. Now, cardiovascular disease and cancers and other NCDs are taking the lead in terms of mortality. Cancer is responsible for around 10% of all death in the kingdom, and this number is expected to rise steadily in the coming years. In terms of incidence by cancer type, this is from the GlobaCan, a WHO organization, and IARC organization, or IARC initiative that focuses on cancer incidence in different type of the world. So in terms of new cases, it was estimated in 2020 to be around 27,000. And this, as you see in the pie chart, colorectal cancer is the most common cancer among both genders, male and female, across all age groups. Breast cancer is closely following colorectal cancer as second most common cancer. In terms of all incidence in female, breast cancer is the most common type of cancer in female. In terms of mortality, or estimated number of deaths in 2020, breast cancer is the leading cause of death in females across all age groups. It is responsible for around 20% of all cancer deaths in the kingdom. This is a very huge number. In other countries, I would say lung cancer probably is the most common type of cancer attributable death, but in Saudi Arabia, it's interestingly that breast cancer is the leading cause of cancer death, followed by colorectal cancer. So how can we control cancer? We know that there is a huge incidence coming on in the next coming years, and how do we from a public health perspective, how do we control cancer? This nice slide, which is publicly available at the NCI, National Cancer Institute in Washington, outlines different stage across the cancer care pathway in terms of how we can control cancer. I'm just gonna try to use the laser here so I can point you to the point where I'm going to talk. So in terms of etiology, I think we need to use public health to improve the environmental, like pollution, occupational hygiene. And we also have a huge research being done around the world and in Saudi Arabia around Saudi genome research project. This is very important in terms of personalized medicine and how can we detect and stratify screening in the kingdom. In terms of infection agents, we need to vaccinate people in those against those viruses who were shown to be a cause of cancer, like HPV, HCV, which doesn't have a vaccine, but it has effective treatment now, and HPV. And we also need to focus on health behavior and improve the research in this area to improve or to push forward the cancer prevention efforts. In terms of prevention, I think there is a great effort being done on tobacco control, especially in the light of Vision 2030 and the Quality of Life program. There has been an extra tax being applied on tobacco products, which we have shown in a study that was effective to decrease the consumption of tobacco products in the kingdom. Diet, we need to improve diet, and we need to improve physical activity. Those three things are parallels in the quality of life program, which comes under Vision 2030. HPV vaccine has been adopted in the West, but I think in Saudi Arabia we don't have that high incidence in terms of cervical cancer, and we need to carefully think whether we need to adopt HPV vaccine or not. In terms of detection, whether how can we detect cancer early? Public health research in the last 50, 60 years have played a key role in improving the detection for cancer and detect cancer as soon as possible before it becomes symptomatic. For cervical cancer, we have pap smear, we have also HPV testing. And interestingly now with COVID-19, there is a trend on self-sampling, which is a research area. Mammography for breast cancer, which we will talk about today in details, is another advancement in the field. And then FET, which is a new test for colorectal cancer, which is a pleasant test compared to colonoscopy. It has been, implemented in Saudi Arabia to detect for cancer in the primary healthcare centers in 2019, I think. But I'm not sure about the new advancement in terms of after COVID-19 pandemic. The other three important things are diagnosis, treatment, and survivorship. They're not the focus of today's lecture, but they are very important in terms of how we can control cancer. Probably we'll talk about them in another lecture. So why do we detect cancer, or why do we put this huge efforts and time and resources to detect cancer early? This graph shows the biological or the breast cancer process. We're starting from the biologic onset of the disease here in this preclinical phase or asymptomatic period where we cannot see the symptoms apparent. The second phase is the clinical phase where we see the symptoms apparent on the patients. So we aim to detect cancer by as early as possible before it becomes symptomatic. At this stage, cancer is detectable, and then we apply the detection method to detect cancer here before it becomes symptomatic. Okay. So one way of detecting breast cancer is mammogram, or the most common way is to detect cancer is the mammogram. It's everywhere. I would say it's almost available everywhere in the world, with some limitation, of course. but it's very, very commonly used. And mammogram is a low dose of X-ray that can help find breast cancer. It takes around 2 minutes to be performed by the technologist, and it's not painful at all, as reported in the literature. And it's very important to mention that not all abnormal mammograms are cancers. Some of them are false positive, which I will talk about in the next coming slides. So cancer or mammograms recommendation vary from country to country based on the cancer registration data or data-driven decision and policies, healthcare systems. But the most, I would say, not common, but the most known recommendation would be the American one, where the American Cancer Society changes the recommendation from time to time based on the new advancement of the field. So the American Cancer Society recommends that all women between 40 and 45 may want, which is just a suggestion, to start screening every year. But for women between 45 and 54, they should get a mammogram every year, and they get invited to take part in this mammography screening. For women above for women who age 55 or older, they can do a mammogram every other year, which is can reduce their risk of being diagnosed with late breast cancer. In Saudi Arabia, the Saudi Center for Evidence-Based Healthcare recommends for cancer screening that all women between the age 40 and 49 to get a mammogram every 1 to 2 years. This is very important because I think there is a trend in the research showing that young women in the Gulf, in the GCC countries and the Arab world, they tend to present with cancer at early age. And as documented by the cancer registration in the kingdom, that incidence in this age group is higher than in another country, which is interesting actually for research. For women between 50 and 60, they should get mammograms every 2 years. Incidence in this age group is similar to other countries, and that's why it's recommended to get a mammogram every 2 years. Women aged 70 to 74, there is no recommendation for screening because women in this age have probably other comorbidity or other health issue they need to focus on other than bringing to the hospital, or other facility which might be cause other harms. So it's not recommended to screen women from age 70 to 74. There are 2 types of screening. Well, actually, there are many types, but the most common type are systematic screening, which is a population level. This is implemented in many developed countries, like the Scandinavian countries, most of the countries in Europe, United Kingdom and United States, New Zealand, and Australia. And there is the opportunistic screening, which is very, very common in developed countries and in low and middle income countries. Both have been shown to reduce mortality, and but it depends on what type of approach should we use. This is more likely to be a local research area where we need to investigate which the best one to use in terms of resource-wise and in terms of healthcare-wise. So the systematic screening is on population level. All women who are in the age cohort for screening are invited to come for screening. This requires large resources in terms of financial, in terms of locations resources, and in terms of staff resources to be put in place to coordinate this. And this also requires a very well coordinated healthcare in terms of referral, in terms of follow-up screening, and in terms of how to contact the patients. The opportunistic screening is different from the systematic screening. Opportunistic screening is basically screen women who show up at the clinic or at the screening center. And women are encouraged to get screening through media, through through public health efforts and through all means that can encourage them to do the screening. Public awareness in this type of screening is a key in terms of success and in terms of increasing the uptake of this type of screening. There was a study in Saudi Arabia in 2015 that shows a very low obtaining or optimizing of breast cancer screening in the kingdom. The uptake was very low, around, I would say, less than 20% of the women in the study were aware of the breast cancer screening being done. But that was a kind of old study that was published, I think, in 2015, but were conducted in 2013. So it's very interesting to now focus on the new efforts and the new media means like Twitter, social media like Snapchat, and to see whether these are feasible to encourage women to get screened. This type of screening is very common in Saudi Arabia and other Gulf countries, and I would say it's also common in low and middle income countries and Arab countries, because it's the most probably it's mostly run by government and by health charities. I just want to mention that there is a list of location of the mammograms in the kingdom, where this location are put in one PDF file and uploaded on the Ministry of Health website. You can find it by this name, مواقع عيادة الكشف المبكر بالماموجراف. This file is downloadable. You can download this file from the website, and you can use it. The link or the Google link to go to this areas is provided in this file. So we talked about screening. We talked about what type of screening. So we need to know now how what is the benefits and harms of screening. Every medical decision or every medical procedure has a possible benefit and possible harms. Whether these are minimal or maximum, this depends on the screening. So for the benefits of screening, it can detect cancer at the early stage. This is going to, of course, help to reduce the breast cancer mortality. There was a study estimating the breast cancer mortality can be decreased by 20% if effective screening is implemented. Also improve overall survival. This is another benefit of screening, and it can also decrease or lower the chance of cancer treatment cost, because when cancer is detected at stage 3 or stage 4, it costs a lot of money, it costs a lot of resources, and care outcome or treatment outcome might not be as comparable as if the cancer has been detected earlier. There are, of course, possible minimal harm of screening, and these are false positive. As you know, almost every test in healthcare system has a chance of false positive. In terms of mammogram, there is a chance that mammogram can find or can detect something look like cancer, but it's not cancer. And this requires more testing, more healthcare visit, and more, of course, associated cost of that. Overdiagnosis is another issue, whereas, mammogram can detect cancer, but that cancer or the low type, or that cancer is a low type of low risk type of tumor, where if left alone is not going to cause any harm to the patients or cause minimal harm to the patient. So that's called overdiagnosis. Of course, we all know the anxiety associated with any big decision in life, and life-changing. Cancer is a life-changing disease, and I assume any possibility or any chance that you are told you are being a possible cancer patient is going to bring a lot of anxiety and pressure on you. So anxiety is another issue here, where we consider the possible harms of screening. There was a study in terms of the effectiveness of the national screening programs or the population screening program. There was a study that was published in JAMA. JAMA is a journal, American journal, the Journal of American Medical Association. It's a very prestigious journal where they publish high impact research. This was a meta-analysis. And this systematic review and meta-analysis showed that there is around 90% overall reduction of breast cancer mortality, but that comes with around 61% of cumulative risk of false positive if we screen women for 10 years. And if we keep screening women at least twice a year for 10 years, that the cumulative risk of at least one false positive or one not good or abnormal mammogram will show up with probably 61%. There is another issue with that, which is a 90% of these cases, or there is a 91% chances of overdiagnosis, whereas as I defined overdiagnosis as that cancer or low-risk tumor that might not harm the patients if left alone. This graphs is my favorite, actually, where they did a lot of good data visualization here on how to interpret this result. So if they diagnose 10,000 women for over 10 years who are 50-year-old, there is around 3,500 who will be normal, and they will not detect cancer in them. And then there will be 300 cases, around 300 cases who will be having breast cancer. Of these, 173 will survive breast cancer, regardless of screening, 10 deaths averted, and 57 overdiagnosed, and 62 deaths despite screening. 6,000 will have at least one, as I told you this. 6,000, sorry, will have at least one false positive result through the 10 years, around 61% of these. And 940 will have an unnecessary biopsy. Okay. I'm just trying to note a slide. Okay. Another big study came about the effectiveness of cancer screening was published last year in the Lancet, which is a very another prestigious journal. And this is called UK Age Trial, where they followed people for around 22 years. And this is a huge or a long time of follow-up, which is sometimes is not feasible in an easy epidemiology study. But this seems a very well-designed and important study or trial. So around 160,000 patients were recruited. Some of them were allocated to screening, and some of them were allocated to regular pathway of care. There was a significant reduction in breast cancer mortality at 10 years, around 0.75 relative risk, which is, a good way of interpreting the result, as screening is a protective of cancer mortality. I want also to highlight another study that came out this year in the BMJ, which is the British Medical Journal, and another prestigious journal. This study was done in India, but it's slightly different from mammogram screening. It's about clinical breast examination, where they've followed people for 20 years, and then before then that they've clustered some part of India into groups, where they some group had or some continents or some areas have trained healthcare workers who help to examine patients' breast. There was a good reduction in terms of mortality by nearly 30% in women aged 50 and older who have received the clinical breast examination, and around 10% downstaging of cancer from advanced staging to stage 1 or 2. I want to highlight the future direction in cancer diagnosis. We've talked about how we can control cancer, what is current diagnosis process, is it effective or not? But now we're kind of in the middle of a very advancement technology, and we need to show this advancement includes research as well, and computing, healthcare computing. So artificial intelligence is one way of helping healthcare workers to do the screening. And there was a study published this year or last year, I'm not sure. I think it was in 2020 about in Nature, which is the most prestigious journal in the world, about how can AI help to detect breast cancer screening. There was an absolute reduction of 5.7 and 1.2 in USA and UK, respectively, in terms of false positive. So artificial intelligence helped to reduce the false positive opportunities or probability. This is in the same study also, there was something about that AI outperformed those who, the technologists who were interpreting the result. Another topic in breast cancer diagnosis research, which is trendy now, is stratified breast cancer screening. Good data can help us do good. Good data can help us actually do good decision or good data-driven decision. And then we need to collect good data to make good decision about healthcare. Stratified breast cancer screening is another topic. To stratify, not instead of screening all the population, we stratify the screening to those who are at higher risk, and this requires a good data analysis and good epidemiology research to identify those who are at high risk of breast cancer. Finally, there is a blood test that can detect. Well, it is assumed to be to detect more than 50 types of cancer. The clinical trial is being currently done in the UK, and it is expected to be rolled out in USA this fall, I guess. This is a very, very good advancement in the field, and I think if succeed, it will be a new revolution in terms of cancer treatment and diagnosis. This is basically what I want to say about cancer screening today, and we'll open the floor for any discussion. Thank you so much.
Thank you. Sorry, thank you, Dr. Saleh, for this presentation. I found it really fascinating, the graphic that you showed, and I think it can bring up a lot of points to discuss. But before that, we have one question from Kamal Thubeti. He asks, wasn't the increased number of cases due to the national screening? I could answer that if you like, or if you would like to.
I think I assume what you're gonna say, but I think in epidemiology, it's very common to see increase in incidence if we increase screening, because if you widen or if you put more efforts in detecting cases, you are going to find cases in the field if you do that. So it's basically okay to it's not seen as a bad thing to see the increase in cases, but it's very normal to see increases in incidence if we increases our efforts to detect cancer.
Yeah, I think there are probably 2 or 3 issues here. One of them is a true increase in incidence due to, like you said, increase in some risk factors. And don't forget, there's a strong cohort effect. So the cancers we see today are not due to risk factors we're seeing today. They're due to risk factors women have been exposed to 30 years ago, 40 years ago, who had a very different lifestyle than we do. I think obesity was lower, for example, 40 years ago, which is a known risk factor for breast cancer. Fertility rates have been going down. That said, of course, all the risk factors combined will not have a huge impact on incidence. One of our professors used to say that the main risk factor for breast cancer is being female. All women are at risk of breast cancer, but for sure these risk factors can play a role. The second factor that may lead to an increased incidence, although usually transiently, is when you implement screening. I would say at the rates we see screening in Saudi Arabia. One study that was that had representative sampling from all regions of Saudi Arabia showed that, I think, let me look at the numbers. Yes, women aged 40 to 75 years who had mammograms in the past 2 years were only 5%. So I don't believe only that small number can lead to an increase in incidence on a large scale. There's a third factor, which is overdiagnosis, also related to screening. But again, at 5% uptake, I don't think we'll see overdiagnosis that will change the rates in the country. Of course, if you have women who have cancer and die of other causes before their cancer is even diagnosed, then you'll never diagnose those cancers. And yes, that's an issue that we'll never be able to find out.
Yeah, and let's not forget and let's not forget about the high proportion of stage 3 and 4 of breast cancer patients in Saudi who present to clinic with late stage cancer. Compared to other countries, I think we have slightly higher proportion of patients who come to clinic with advanced cancer. If we have succeeded to detect this cancer, of course, we're gonna downstage cancer.
Yes. So if there are no other questions, maybe I have a few issues to discuss. The first one, so I think we all agree that some sort of screening is necessary. We've all been touched by breast cancer. Some of us have lost people due to breast cancer. But there are a few unanswered questions. Of course, the discussion internationally is still going on, but in Saudi Arabia especially, there's the issue of when to start screening. I've seen there have been some publications of mostly opportunistic programs that have screened women as young as 19 years. There is also a pilot program that started screening at age 35. I'm not here to say whether this is right or wrong, but what is known about mammography is that the younger a woman is, the more difficult it is because they have denser breasts. That's the biological reason, but also because we have a pretest probability, and the lower the probability is of a woman having breast cancer because she's younger simply, the more risk you stand of having false positive and its consequences of unnecessary biopsies or even surgery. So yes, age to start the program, I think. I don't know if you have any comments on that or if anybody else does. I would like to hear it.
Well, I think you're right. I totally agree with you. And to implement that program or any other program, I think we need to look at local data and assess whether that is feasible and whether we need that resources to be allocated to such program or we need it in something else. I think cancer is, of course, is a major public health problem in Saudi, and with this sedentary lifestyle, it's becoming more and more issue. Cancer prevention is important and is going to help in reducing the cancer incidence and addressing the needs for those who need treatment. But the issue is you invest in cancer prevention today and you didn't see results in the coming 30 or 40 years. That's the thing. So we need to think carefully about what kind of screening we adopt, whether that is feasible to do in Saudi or in the Arab world, in the Gulf countries, because we have slightly different population, and from population to another population, from different ethnicity to a different ethnicity, breast cancer risk tend to differ.
Yeah. I'd like to also add to that. You mentioned the incidence for breast cancers. I think the reason these programs have started quite young is because of that we see breast cancer in young women, sometimes truly as young as 19, although it's quite rare. I'm not aware of whether the age-specific incidence is higher than in other countries, or if the numbers are higher in young women because of the demographics of Saudi Arabia, because there are so many young women.
Yes.
I don't know do you know whether it's actually age specific? Yeah.
No,
That's one thing.
I've never come across any study that compared age specific incidence rate to age specific incidence rate in other country. I would say, Dr. Fatina, do you have any question?
Comments? Sorry, we didn't see I don't see any raised hand here for me. I think
I did not see it either.
Oh, okay. It's in the okay. Now I see it.
Yeah.
I think
okay. Is my voice
yes, now
clear?
I can hear you. Yes.
Yeah, okay. Good afternoon, all of you. Thank you for the nice and interesting topic, actually. The controversy is going all over the world. However, the last 4 years, let me first introduce myself. I'm Dr. Fatina Tahan, the Director of Cancer Control Program, where breast cancer screening program is under it. So the controversy is of the screen or not to screen have been since, let's say, 2009, where we have the problem with financial problem in the state, and then it increased to a lot of issues, mainly related to budgeting and finance, where the government usually cannot really cover the whole cost of the screening, especially in countries where they do millions per year. However, this is also was because of conflict of interest with the new medication, with the medication also for the late stage. And until recently, when last 3 years back, a lot of reports and data come from many programs. Countries who having the real what we say population-based screening program, and showed mortality between 25 to 40% reduction, especially within the European countries. And there was one big fake study, and there was a lot of issue here, was also published in Lancet, and then there has a lot of things. Unfortunately, I don't have it with me now to poster it. And there is also one of the unrealistic research, which was released from Canada, and then after that they draw back this. So all the good research which we have, our data they publish, it showed definite reduction in the mortality. So this is why it's very important, as the cost, of the treating the cases or women with advanced case, it sometimes reach to 1 million riyals. So when you treat in an early, it's totally different than late. Now the incidence, you were talking about the incidence and the age. The age, let me tell you, there's a lot of data, including our data, which will be published soon, maybe early 2022. It shows that we have more than 45% of our lady under 50. So this is why we start our screening at age 40. We cannot start at 50, where we have a good number of cancer happen between 40 and 50. Another thing, the incidence, yes, true. We have increase in the breast, the risk factor, what we call it the modified risk factor, because as the doctor said, the age and sex is the most important factor. But the modified one, which is according mainly our lifestyle is main, and this is definitely one of the major risk factor now. This is why we have this a lot of campaigns where 40 and 40, you know that 40 you can prevent and 40 you can detect early. So this is why we insist about the awareness of to adopting healthy lifestyle, because obesity, especially after menopause, can cause also increase the risk of breast cancer. And if you do a good exercise or walking or activity, you can reduce up to 12%. So this is there is definite increase, and aging also, because we are also a young generation, and becoming now the median age is 75, increased to 75. But also you don't know that how much the effect of the program we are running. We are doing more than 100,000 every year, so mammogram, and we detect more. We detect, let us, the percentage of detection is 7 per 1,000. So it's almost the same like other country, because the people, they said this is there is a low incidence. The low incidence because until now, unfortunately, the ladies they don't come early. They think that when they see because of a lot of reasons, but one of the main reasons is what they think, if they start to see something, then they will approach or they go to the doctor. And this is why one of our campaign was under logo of لا تنتظري الأعراض افحصي الآن. Now I'm talking to you in a clinic, middle of my clinic, and until now I saw two ladies, one 44, one 48. Both they came to my clinic. Now I'm doing ultrasound for them, and when I'll do biopsy after that. Both they never think that they want to do, because although they know that mammogram is important, but maybe it will not affect us. So I think we have to work a lot on the awareness, and maybe there should be some policy like to bring these ladies to do the because we know that freedom, it's a freedom, and every woman have right to do or not to do, but this freedom should stop when it affects her family and affect the society. Now we know woman is a big power in the as she's very effective. She has big role in the even with the financial aspect, and so it is all. We are the ladies is 49% of our community. So definitely the program bring a lot of ladies to the. So it is the increase of incidence. We see it. It's mainly from the it has a point. The program has a rule on it. 30% of our data for the cancer each year it comes from the program. The one they register for, so they register.
Yeah, very useful information from you. And as Dr. Fatina said, we have 45% of cases under 50. It's truly a problem, of course. And the issue maybe that needs to be researched is what's the best way to detect cancer in this age group. I'm talking now under 40. So as Dr. Saleh mentioned, there are screening programs that screen women from age 40 and then from age 50. So what do we do with the large numbers of women who are under 40? Is it better to combine modalities, to use clinical breast examination or ultrasound, as was mentioned? These are interesting topics to research.
Let me add something. That the best thing for ladies under 40, if she's not high risk, is the awareness. teach her how
Yes.
to look and examine her breast. This is the
Yes.
only way. And if she has anything, she has to, finding, she has to go to the doctor and do the checkup. I think this is the best thing. Awareness, awareness, awareness. Thank
Yes,
you for all of you.
Thank you. Thank you, Dr. Fatina. Yes, awareness, of course, the stage distribution for breast cancer has improved over years, but it's not only binary, either screen or be diagnosed late. Of course, awareness can strongly affect the stage distribution. And if a woman presents as soon as she detects a lump, then her probability of surviving her cancer are much higher. I was just looking at other.
May I just comment
yes,
to
go
Dr.
ahead.
Fatima? Well, thank you so much, Dr. Fatima. We all know who you are. You've been a great champion in pushing cancer prevention efforts in the kingdom for the last 20 years. So thank you so much. Very, very interesting to hear this. I think as echo Dr. Iman comments on that, we need to do research on especially how to diagnose cancer early in this age group from 40 to 49. This is of interest, and it's a local issue. We need to address it with, especially from a genetic point of view. And I'm aware of a couple of our several researchers who do this, or are interested in investigating this on the issue on the GCC level.
Thank you. So yes, I would summarize the main issues in our current screening program are related to uptake and quality. As you know, mammograms are read by radiologists, and the quality of interpretation can differ. In one study, the recall of women with positive, the recall of women was very high, up to 30%, although this is a bit of an old study from Qasim. So to have a built-in quality assessment measure, of course, is much easier when you have a systematic screening program. Requirements for a systematic screening program, others may have other ideas. I believe that primary care is the key to a systematic screening program. And alhamdulillah, we're seeing more of efforts directed towards primary care. Women trust their primary care provider, they build a relationship with them. And through primary care, women are able to make informed decision about being screened. And I think this is the main aim of such a program in the end, especially given that we know there are some potential risks, although reducing mortality is the main aim, and it's a very strong aim. It's a very motivating aim, but women should still have that choice and be informed about any risks she's taking. And studies have also shown that even with informed decision, most women do go for screening. I'm just looking at some questions. Yes, so one of them was about breast self-examination. And I think, yes, she was saying that it might increase anxiety and has a low yield. A lot of women have lumpy breasts. They're not experienced to examine themselves, and it can cause a lot of anxiety. As Dr. Saleh mentioned, the study about clinical examination in a country like India was it had a very good reduction in mortality, actually, almost the same you would see usually with mammography. And in a setting like that, it's a very good alternative, especially that community workers can be trained to carry out such examinations. You don't require the infrastructure that you would usually need for mammography. I think in our context, mammography can be available. It's widely available, but as mentioned, maybe for younger women, clinical examination can start as early as 20. These are also questions that need to be answered. Also, so we're asked to compare breast and cervical screening in terms of effectiveness. Breast and cervical cancer are, I think, very different topic. No, they're similar in many ways and different in others. So, as you know, breast cancer is the most common cancer in Saudi Arabia. Cervical cancer is quite uncommon, not even one of the top 10. Cervical cancer screening is very cheap, and cervical cancer affects women in young age, younger than breast cancer in many instances. It also affects women usually of lower socioeconomic status, as opposed to, of course, breast cancer affects women of all socioeconomic status, but it's known to be more common in women who have less children, higher education. I think the main advantage of cervical cancer screening is that it's actually considered to be a form of primary prevention. Sometimes it can be both primary and secondary, but it can actually remove cervical precursors, while breast cancer screening will detect early cancer. I don't know if Dr. Saleh has anything else to add.
I think we might leave the topic of cervical cancer screening to another, because it's very interesting, I guess, especially for, now it's very common in the West, given the different lifestyle and life choices. And self-sampling is being administrated there, which is very interesting to see. I think over the next coming 3 to 4 years, we'll see a lot of literature or studies about self-sampling. Yes. And this might be applied on breast cancer screening and how to empower women to do self-examination.
As you know, my PhD topic was about cervical cancer. And
I know.
Ending it during COVID, and that was one of the things in the conclusion, that self-sampling is I think it would be very successful here, because it's culturally appropriate in terms of privacy, and also women can do it at home. It can be mailed to them in remote areas. And but yes, this might be a topic for another.
How reliable is it going to be?
That's another question.
Yeah, that's yes. Let's wait and see the UK data on this, which is, I think, going to be published in the next coming 2 years. Anyway, yeah, I don't have anything to add regarding breast cancer, but I just want to thank you and thank Manal and thank the Public Health Authority. And I also special thanks to those who have been pushing cancer prevention forward, including Dr. Fatina, Dr. Zahrani, the non-profit organization in the Kingdom, Abdul Latif Jameel Center for Screening, of course, the Ministry of Health for the great efforts to map those breast cancer screening centers and make them available. And these are I think, are all good efforts to do cancer prevention in the Kingdom. Thank you.
Thank you very much to Dr. Saleh and Dr. Manal and all the attendees, and Dr. Fatin, of course, for her input. And yes, we hope to have other discussions like this in the future.
Yes, we hope we can continue discussing cancer epidemiology in our context, inshallah, in the coming times.
Thank you, Dr. Saleh, Dr. Iman. It was really great discussion, and we wish we can continue like forever discussing the breast cancer.
We can.
And survival screening, of course, and the cost effectiveness for both programs. But we promise that we will have another discussion just for cervical screening and HPV vaccination and the effectiveness of this program here in Saudi Arabia, inshallah.
Would love to hear from Dr. Iman, her experience on
the
topic. I know she spent almost 4 years. she spent 4 years of her life searching this topic, and I'm sure she's going to bring a very interesting insight on the topic.
Especially now they will start that like the HPV vaccination here in Saudi. So we want to hear really from Dr. Iman about her point of view and what the research.
I actually don't have an opinion about that yet.
What's the research show as far about the cervical screening and the cost effectiveness of cervical screening, especially here in Saudi Arabia?
Yeah.
Inshallah, this will be our next session.
Inshallah.
Sure.
Thank
Great.
you.
Thank you for your time, and
Thank
thank you for all the participants and the people who attended this webinar. Thank you again, and have a good night.
Thanks.
Bye-bye. Shukran.
Bye.
Bye.